Welcome to the Nourished Child Podcast, a show about childhood nutrition, feeding kids, and dealing with the ups and downs of growing a healthy child. Here's your host, registered dietitian and childhood nutrition expert, Jill Castle.
Hey there, it's your friend and pediatric dietitian, Jill. Welcome to the Nourished Child Podcast. If this is your first time here, we welcome you with open arms. Today, we're talking about body composition and specifically body fat and how it might affect your health or your child's health. With me today is Dr. Robert Dubin. He is a triple-boarded internist, endocrinologist, and obesity medicine physician. He is the program director for the Obesity Medicine Fellowship at Louisiana State University Health Sciences and currently works at the Pennington Biomedical Research Center at Louisiana State University. He's the associate editor of the journal Obesity and is a fellow of the American College of Physicians and the American College of Endocrinologists. And his current area of research is understanding the changes in body composition that occur when using the new incretin-based agents, things like Ozempic and Wegovy. We aren't going to dive into that piece of his research too much, although at the end of this interview, we will touch on it. I have been interested in body composition for a long time, and since we haven't discussed that on this podcast yet, I thought he would be a great introduction to body composition, just helping you understand what we're talking about when we talk about body composition, where body composition is going in terms of innovation, and how it's affecting how we even talk about weight. You'll be interested in hearing that Dr. Dubin is a big proponent of shifting the language away from the number on the scale to specifically your body composition. We talk about the different compartments of body composition. We talk about body fat, where it is supposed to be and where it's not supposed to be, and what happens when it gets deposited in places where it's not supposed to be. We talk also about what happens when individuals lose weight. And in this conversation is more of an adult-based conversation because we don't promote weight loss in children unless they're under medical supervision and lifestyle behavioral interventions are underway and have been addressed. But he differentiates the results of total body weight loss versus body fat loss. And he also talks about loss of muscle when there is total body weight loss and how that can affect one's health. At the end of our conversation, we do talk about the GLP-1 medications and how they are changing body composition. And we get some of his insight into what we should be watching out for and taking care around, as well as innovations in body composition on the horizon. So without further ado, here is Dr. Bob Dubin. Dr. Dubin, welcome to the Nourished Child Podcast.
Thank you. It's good to be here, Jill.
It's good to be here with you. We met at a conference. I listened to you present a topic on GLP-1s and obesity. We might dive a little bit into that in our conversation today, but I really wanted to talk about body composition. I've never talked about it on this show before, and I know that's an area where you have devoted much of your career in terms of research. So before I ask you questions about that, can you tell us a little bit about your work and how you got into the work that you do today?
Sure. Thanks for asking. Before coming into research at Pennington Biomedical in Louisiana, I was a practicing endocrinologist who just saw patients and did research part-time. And I've been involved in the area of diabetes and obesity for many years. And I felt that it was a good time for me to focus 100% of my energies in the field of research and teaching and things of that nature.
Mm-hmm.
So it was really everything that I did in the past with patients in the real world that brought me up to this point. And I was fortunate enough when I started working at Pennington to work with two just incredible leaders in the field of obesity, Dr. Frank Greenway and Dr. Stephen Heimsfeld. And over the last several years, I've been really taking a deep dive into the area of body composition, which hopefully we'll talk a little bit more about, which I feel personally is really what's in the future and what's going to be exciting for nutrition, obesity, and rather than talking about weight, we're talking about the organs in your body and what's your body made of. So that's really how I got into it, and I'm loving every minute of it.
Yeah, I think you're right. And I agreed with you when you spoke about this, that is sort of on the cutting edge of where we're going next. So I have a parent audience, lots of pediatricians, people, healthcare professionals that work with kids. And so I want to sort of explore this topic using the lens of we're talking to a parent, for example. So what is body composition? How would you define that to a parent?
Well, body composition is just defining the internal parts of the body. So when we look at someone, they are made up of the different parts of their body. But if we're able to look inside of the body, we could see that there are primarily 4 what we call compartments. Compartment number 1 is bone. Bone kind of has its own compartment. And the second compartment is water. And for most of your listeners, they know that we are mostly water. I believe it's like 60 or 70% we are made of water. The third component is what is known as lean mass or fat-free mass. You could use those somewhat interchangeably. And that is the area where we do most of our research. And that includes skeletal muscle, like your muscles in your body that we all think about. It includes the organs of your body, the heart, the liver, the gastrointestinal tract, the brain. And it also includes everything in between, like the connective tissues and the tendons and things of that nature.
Mm-hmm.
So that's really, in a nutshell, what we look at, and that's what body composition is.
And the fourth component would be fat? Body fat?
Thank you. The fourth component is fat. Exactly. Okay. So that's, you passed the exam. We're going to certify you as a body composition expert.
Awesome.
Mm-hmm.
Okay. So when we're looking at body composition versus total body weight, why is that advantageous? What are we getting more of when we're looking at body composition versus just somebody who stands on the scale and we see a number?
Yes. Well, you could use this in several ways. First off, in our field, we're managing type 2 diabetes and obesity. There is an excess of fat tissue, or what we call adipose tissue. And while adipose tissue is very important in the body, unfortunately, too much adipose tissue can cause problems. And that would be type 2 diabetes, heart disease, high blood pressure, things of that nature. Mm-hmm. So, in order for us to know what's happening, if you put someone on a diet, right? You put someone on a diet and you ask them to lose weight. It's nice to be able to find out what part of that body composition is changing, because the bottom line is we don't want to affect the skeletal muscles. We want to leave those alone, and we want to focus in on fat loss. Mm-hmm. So don't think weight loss, think fat loss.
I like that. And when we think about body composition, I did a little bit of research on it for this book that I wrote recently. And, the genetic component of size, there's a good amount of research on our size, our shape, where we place body fat is kind of genetically determined. That's what I discovered in my research. I would love to hear your perspective on that as somebody who's doing that kind of research. How much control do we have over our body composition versus how much of it are we sort of predetermined, genetically influenced by?
Well, Jill, I think a lot of this, in terms of genetic influence and pre-programming, we don't know so much about this as we'd like to. We are trying to get more answers. In fact, we have body composition techniques to evaluate body composition in little babies. Not that we're putting them on diets or anything like that, but it's important to look at how that might predispose them later in life. So the effects of genetics can never be overstated. In 1994, we discovered that obesity was a disease, and we found a gene called the OB gene that caused rats to become obese. So if from that time on, almost 30 years, we understand that there are many genetic predispositions to developing obesity. You will see this in pediatrics. There's a disease called Prader-Willi, which is somewhat rare, but it's out there. There are other diseases where leptin is having problems with sensitivity, and there are probably at least a dozen or more genetically predisposed diseases that cause obesity. So the big thing is this is something that we need to learn more about, because we've identified some of the genes, and we're just getting to understand what is the problem in those genes. There's another one called MC4. There are so many of these receptors and things of that nature that are not performing properly, or there may be an enzyme deficiency that we're just starting to understand. Identifying them is one thing, trying to figure out exactly what's happening and to try to figure out a treatment is what the obvious goal would be for that. So I wish I had better news to give you and tell you, yes, we've got this all mapped out, but it's out there. And if anyone's concerned that they might have a family member with a genetically predisposed cause for their weight, they should see someone who is an expert in this area, typically like a university setting.
Yeah. When you think about carrying excess body fat, when you think about that, is that, when we look at body composition as a whole, is that excess adiposity what is driving the health conditions that some individuals experience related to that excess?
It really is the crux of the matter in so many of the disease processes. So it's as simple as you either have too much adipose tissue in terms of size, right? It's either a problem with the cell size being too large or the number of cells being too many. So if you just break it down to a very simplistic sense of inventory, it's either too big or there's too many. And once those fat cells get deposited in places where they're not supposed to be, that's where the disease can set in, such as liver disease, where the fat tissue infiltrates into the liver. Very common. We study the infiltration of fat into the muscle cells because it's such a risk factor for cardiovascular disease and other serious conditions. There's fat around the heart, pancreas, wherever there's an organ and there's not supposed to be fat in it. If there's fat in it, it causes dysfunction, such as in the pancreas, and many other organs. So yes, fat is the culprit here. And if we're able to find a way to address that, I think we'll really make strides in the future.
And I just want to clarify for listeners out there, it's not what you're talking about is fat that has infiltrated or deposited into organs. It is not the fat necessarily that is on your hips or in your child's belly that, that what I hear you saying is there's a difference. And I guess that kind of taps into one of the questions I had for you around this idea of children who carry extra body fat. And I work with children who carry extra body fat. We talked about this. Some children I work with have no metabolic dysfunction, and others I work with do. What do you make of that? And is that related to this idea that body fat gets deposited into the organs?
Yes, Jill, you're absolutely correct in describing what we would define as subcutaneous fat tissue versus visceral or intra-organ fat. There's a big difference there. You will also see this play out in male versus females. The male type, where they have this very large abdominal area, is usually indicative of a metabolic problem, such as high blood pressure, high cholesterol, and diabetes. Where in females, they get very lucky sometimes where they have this, they would call it I believe they call it a pear shape or gynecologic typical figure is what they call it. That around the hips and around the buttock area tends to be very benign in nature, and it's not dictating a disease process. So it's all about location, just like when you buy your home, where it's at.
Okay.
So, just like food, where, there's people will sometimes demonize carbohydrates, right?
Yeah.
No, it's the same thing with fat. You need fat. If you don't have fat, you can't survive. And there's good fat and there's bad fat. And in our body, there is appropriate fat deposition. And then once it starts going into those other places, it's not good.
When fat becomes visceral fat, gets infiltrated into the organs, is that easy or challenging to reverse?
Fortunately, the fat in organs, we believe, based on some of the bariatric data, that it's the first to go. When you're scheduled to have bariatric surgery, the surgeon will put you on a very strict diet for 2 or 3 weeks. Very, very low carb, low calorie. And what happens during that time is that your liver will just shrink, right? It'll just go before the surgery. And they do that so that when they go in there with those laparoscopes, they can see what they're doing.
Yeah.
And we have a theory based on the GLP-1 treatments that when you're using those, one of the first places to go is in the liver and in the muscles. The muscles are a critical part of this equation. And we believe that it might kind of give us the clue as to what's going on metabolically. So very important, very important.
So getting back to the 4 components of body composition, you said bone, and that seems like it's, we know in childhood, kids are in a bone building phase for the first 2 to 3 decades of life. They're accumulating bone, right? And later in life, we're losing bone after menopause, for example. The second component is water. And water, that's sort of like we're hydrated, we're dehydrated, right? That can fluctuate. Is that correct?
Definitely.
And then I want to hone in on this lean, fat-free mass, the muscle, the organs. How are you measuring? How are you measuring body composition today?
Excellent question. Body composition in research, if we have a study, as we here at Pennington, we have 100 studies, and we're going to measure body composition, we'll typically use a DEXA machine, which is a dual energy X-ray absorptiometry. And it's like an X-ray, and it basically takes pictures of your whole body, and it's able to do a pretty good job of separating out the bone, the fat, and the lean mass or the fat-free mass. Water isn't part of that measurement with DEXA, but there's other ways to measure water. So DEXA is probably the most common in research settings. If you go to a obesity clinic, they might do what's called a bioelectrical impedance. It's a little device where you just put your hands on this metal bar and it sends a electrical voltage through your body, and it's able to identify the water and give you an estimate of fat and muscle. Very crude, but it's acceptable in for clinic. And then in the other research settings that we do here, the gold standard is with MRI scans. MRI scans allows us to directly measure body composition, such as skeletal muscle. The problem with DEXA, Jill, is that DEXA combines the skeletal muscle with all of the other things that aren't fat. That would be the organs, the tissues, and all of those things. Everything that's not fat is kind of lumped into that lean mass or fat-free mass. So that's also just an estimate for skeletal muscle. And you could get into a little bit of trouble. It's probably not a big deal for your listeners unless they're going into research. But needless to say, it's part of really figuring out what's going on in your body, because this is just a little over the top here, but the DEXA machine, remember I was telling you that there's fat in the muscle?
Yeah.
And it's the first to go. Well, the DEXA is not able to differentiate that fat that's in the muscle from the muscle itself. So it just counts it all as muscle. And then when you go on a diet or you go on a GLP-1, it goes really quick and it picks it up as a loss of muscle, lean mass. So that's one of the...
That's a challenge.
It's a challenge, and it's one of the limitations to using DEXA. And that's why in a lot of our studies that we're doing now, we're using sub-studies of smaller patient numbers that do MRI scans.
Yeah. So I have a doctor who has a machine that you stand on. You get down into your underwear and you stand on with your hands out and you spin around, and it produces your body composition, your muscle, your bone, your body fat, and it can detect visceral fat. This is in like my regular general practitioner's office. Are you seeing more of these sort of in-office body composition measurements? I'm seeing it, in my little town with my little doctor. He's really interested in, he doesn't care what my weight is. He wants to see my body composition, and he wants to watch it over time, which I think that's meanthink It's a little disturbing when you get your results. No.
Right.
But I think it's so interesting. And I guess my other, comment around that is anybody doing this with children, or is body composition in like a research phase with children? Is anybody looking at it and getting away from get on the scale and we're going to look at your total number?
Definitely. Here at Pennington, in conjunction with several large trials, we are looking at obesity trials, and we're doing body composition in pediatric age. As I mentioned before, here at Pennington, we also use body composition analysis. We have what's called a P-pod. There's a bod pod, which is used a lot. It's an air displacement type, and it gives you very accurate body composition. They have a P pod for little babies to go in. So to answer the question, they are measuring body composition in babies and pediatrics, adolescents, because it's so important. The whole issue of bone density and bone loss and growth is being measured and followed. Clinically, there's a little bit of a gap because most of the measures in clinic are using bioelectrical impedance because it's what's available. It's cheap and it's pretty good estimate, but it's not research grade. But it's out there. There are a lot of new things on the horizon. I'm fortunate enough to work with the leader in this field, Dr. Steve Heimsfeld, and he and a couple of groups are doing digital photography. I think I showed this at the Berlin meeting, where you could take pictures of someone with your phone, and through some real high-tech AI, they're able to come up with body composition, which it almost sounds like that's what your PCP's using, because he's got this thing where he spins you around. That isn't prime time. He must have a secret input to Steve Heimsfeld or someone that is able to get that, because you don't have to do that for body electrical impedance. You just grab and it just sends a little shock through it, but you don't have to spin around. There's a lot of high tech stuff coming. It's an exciting field. Very exciting.
So let's say you measure the body composition of an individual, child or adult. What do you do with that information? What does that tell you as a doctor, as a healthcare provider? What do we do with that information? Well, even first off, what is a normal amount of body fat? What's a healthy amount of body fat?
So even though body composition analysis and the science of body composition has been around for over 100 years, there's very, very limited information in terms of standardization. So yes, there are some general agreements in terms of how much body fat versus muscle or lean someone should have. Believe it in pediatrics, and females typically are allowed a little bit more based on their body type, up to about 30%, and males 20 to 25, somewhere in that zone. But there is very little in terms of published data out there. I think you're going to be seeing a lot more of this, Jill, as we get more information, particularly using more accurate types of body composition. So my hope is that in the next 10 years, you're going to be seeing available body composition techniques in the office in real time that are accurate, and that people will be able to come up with standards and some recommendations. Right now, if we do a scan, it serves as a baseline, right? Just like you had. That's your baseline. We'll put this in your chart. Do your thing. Come back in 6 months or a year, and let's compare to see how you're doing.
Yeah. So is this going to replace BMI?
Great question. BMI won't be replaced because BMI is a very good screening test, right? It gets you in or out of the door. That's it. After that, you leave it behind because it tells you nothing. BMI is good for epidemiologic studies, 10,000, 100,000 subjects, but not for one person. So we'll still use BMI, but like in that Lancet commission that was published in January, we're looking at different types of obesity, pre-obesity, particularly in the pediatric population, Jill, where they haven't developed any of those comorbidities, right?
Yeah. Did you happen to see the American Academy of Pediatrics response to preclinical obesity? They came back and they said that under the age of 9, most kids won't show any metabolic dysfunction.
Right.
So it's, where there might be excess body fat and compromise eventually down the road. In that first 9 years of life, children typically don't show metabolic change.
Right.
I thought that was very interesting.
Well, we have to be careful within the growth period, right?
Yeah.
And understand that within that time period when kids are growing, you don't want to stigmatize anyone. You need to be really careful and make sure you're, working with someone who knows science and isn't telling you to do something that it might harm your kids, and put your child on a, 1,000-calorie a day diet. Well, I don't know if that's the best thing, So I think the Lancet Commission was, mainly adults, experts. There wasn't a huge representation for peds and for adolescents. So it doesn't surprise me that the pediatric groups will come out and give their own take on that.
Yeah.
I do think it will help, though. I think it's going to help because of the rise in type 2 diabetes that we see in kids. I think that's a instant red flag, right?
Sure. Yeah. Yeah.
Yep.
So let's talk about improving body composition. We've measured it. Let's say you have a patient, you've measured their body composition. They have excess body fat or too little muscle. How can a person improve their body composition?
Well, Joe, that's the great news to all this. As complicated and as depressing as some of this might seem, it really doesn't take a lot. We knew back in the Look Ahead trial that all it takes is about a 5% weight loss to have improvements in many outcomes, right? Mm-hmm. So the same thing applies here. In fact, I just read a study this morning where there was a 3-month study using a new drug where there was only about a 6-pound weight loss, but it was all fat. And it really resulted in significant improvements. Whenever you can make those changes and lower your fat to lean ratio, you're almost inevitably going to see an improvement in those other outcomes that we talked about, be it blood pressure, cholesterol, blood sugar, and so forth. Mm-hmm. So I think those are the key components to all this. And, if we could change the trajectory that we're on right now and focus on I don't know what generation is in the pipeline now, X, Y, baby boomers, right? Whatever that, if we could really focus on bringing them through so that when they're at their adult stages, they've turned things around and they don't have this epidemic that we're facing today of cardiovascular disease and obesity and type 2 diabetes.
So it's a reduction of body fat and a building of lean muscle tissue.
Yeah. So easy peasy, very easy. It's when you lose weight, we don't have any specific recommendations, Jill, in terms of, you have to be on a GLP-1 or, you need bariatric surgery. No, it appears as though all facets of weight management, diet, exercise, medications, surgery, all provide a loss and improvements in those ratios. A lot of this hasn't been mapped out real well. But remember, a little goes a long way. So in an example, if someone wants to lose, say, 10 pounds, and if you're making sure you're focusing on getting adequate protein, which is usually about 1 gram per kilogram, most people it comes out to 50 to 100 grams of protein. Talk to your dietitian to get that specific so that you know your protein requirements, and then to do resistance-based exercises, which may be walking or it may be using some resistance bands. You don't have to join the gym to do this.
Right.
If you do that in conjunction with that calorie restriction and that weight loss, then you're going to get what we're looking for, right? We're going to get that quality weight loss, which is what this is all about.
Yeah. Let's just quickly shift into GLP-1 medications. Some kids are using them. I don't have a lot of experience with children on GLP-1s, but I know some are out there. You have more experience, I believe, with adults on GLP-1s, and you're seeing body composition changes in that area. What are you seeing? And if there's a parent out there listening who might be on GLP-1s, what do they need to be concerned about as they are progressively losing weight?
Great question. I'm not a pediatrician by trade, but the data that I've seen in some pediatric trials is pretty remarkable. And I would speak to any of your listeners out there that have a child who is in that top end of the BMI and you haven't been able to really figure it out and the appetite is uncontrolled. I'm thinking about the Prader-Willi type, even though that's not specific to your patient population. The GLP-1s, Jill, seem to hit this switch in many people, not everyone, and it's not the cure for obesity, but you talk to people, including parents, and they'll just say, wow, it's not the focus anymore. Mm-hmm. Johnny has really been able to get control of his appetite for the first time in his life. So yes, those are the success stories that we hear from people on GLP-1s. But at the same time, everyone and their mother is using some sort of compounded GLP-1, not being prescribed properly, and who knows what's happening. These are powerful hormones. These hormones work on the brain to really do a lot of significant physiologic changes that could be harmful if not used properly. Number one, we just touched on this whole area of losing lean mass. We talked about the issue of growth, right? Mm-hmm. You don't want to stunt growth in someone going through those growth years. And there's a lot of specialty care that goes into this. So again, speaking to those people who may have a loved one or a child who you may be considering this as a possible treatment, see a specialist, see somebody who's really good with this. And I do think it's worth looking into, in that case. The side effects, GI side effects could be very, very significant: nausea, vomiting, and that has to be monitored. Not everyone can tolerate these. Uh-huh. And really the biggest thing is accessibility. These drugs right now have been so out of reach for so many people because they're so expensive. And you finally find something that helps, your son or your daughter, and you're seeing some progress, and you end up not getting insurance coverage. And what happens is about 50% of users of these drugs end up stopping before a year because typically economics.
Yeah. And then the weight potentially comes back on if they haven't worked on the lifestyle behaviors.
The weight will come back. These hormones, these drugs, as good as they are, as powerful as they are not a cure for this disease. And when they are stopped, the weight will come back. There are a few rock stars out there who figure out how to do this. Maybe it's genetic. Maybe they get lucky. I don't know. We don't know why. There's a select group of people that could do this and stop and maintain, but it happens. Mm-hmm. I think having a good dietitian and having a supportive network is key there.
Yeah. Yeah. Anything else you want to share about body composition, innovations in the future, how it might help direct management of obesity?
Yeah, I think we've touched on the key take-home messages, the pearls being that we're getting away from BMI. We're getting away from the whole stigmatization of obesity, which clearly affects those younger age patients and their families. I think the advent of having this new technology with body composition and having an insight, right? It's almost like when we got all the technology that was able to see little babies, in utero. Wow. It's kind of like that now with the body composition. It's like, wow, you could really see what's happening in real time. So the hope here is that it's going to make our healthcare system and our delivery better because we're not focusing on just a number on the scale. We're focusing on health and wellness, which is all that what this is all about.
Yeah, well said. Well said. Thank you so much for sharing your expertise and your insight on body fat, body composition, and how GLP-1s might affect that. I haven't covered that on the show before. I think it'll be very informative to parents, and I appreciate your time and your knowledge. Where can people find you, learn more about you, learn more about your research?
I am available at pbrc.edu. That's the Pennington Biomedical website. If anyone's in Louisiana or if they're stopping by Louisiana, Baton Rouge, stop by. I'll give you a tour. It's an amazing facility. Robert Dubin, MD.com website. I'm on Facebook and all those other social medias, but I don't know my handles. I'm sure if you type my name in, it'll show up. Or better yet, I could ask my wife, Carol, and she'll figure it out. Or
You're too busy. You're too busy to spend time on social media.
Wow.
I do have to say a little plug for the Pennington Biomedical Research Center. I did not realize you guys were the ones that created the DASH diet. Or helped inform.
You know what?
Yeah.
Pennington has been around since the 1985, I believe, and we've been at the forefront of every breakthrough in nutrition and obesity, and this is a
incredible
Hall of Fame here. It really is, and just to be able to work with some of these people, and stop by their office and talk to them. It's like, hanging out with Mick Jagger and Keith Richards. It's really cool.
That's awesome. That is so awesome. Yes. Well, thanks so much for coming on the show. I appreciate it.
Jill, thank you for having me. I hope it helps. And if there's anything I could do to help with any of your listeners or the future, please let me know.
I will. That's it, folks. I hope you enjoyed this interview about body composition, body fat, body muscle, lean tissue, and how it changes over time. Although he's not an expert in pediatrics, and that changes the conversation a little bit because remember, in growth and development, we're accumulating body muscle and body fat, and the body composition is in dynamic change during childhood. But his conversation and his insight really gives us a lot to think about, I believe, particularly as it pertains to changes in body composition and where we need to be sort of focusing our efforts as healthcare providers, not only in terms of how we talk about weight and body composition, but also targeted areas. We can be more targeted and get healthier, better results for clients. But the other part I wanted to point out to you is that Dr. Dubin never mentioned this, but he also has a website of his own, and he has a YouTube channel where he educates about diabetes and body fat and body composition there in a very entertaining way. He's also a musician, and he incorporates that into his YouTube video. So take a look over there if you have the time. The other piece I wanted to mention too is that the Pennington Biomedical Research Center at Louisiana State University is the world's largest academic nutrition research center. He and his colleagues are on the cutting edge. So they also, and I was surprised to learn this, but completely intrigued, they also helped create the DASH diet, which is the diet that is the preferred approach for reducing hypertension in adults and in children. I included some information about that diet in my book, Kids Thrive at Every Size. So, 2 little tidbits we didn't get to talk about in the interview, but I wanted to make sure that you knew about those things. That's it for today, folks. I'll see you in a couple of weeks, or if you're watching on YouTube, I'll see you there. If you're listening on your podcast, I'll be in your ear in 2 weeks. In the meantime, don't forget, we have tons of articles and resources for you on thenourished.child.com. And if you need more help for your family or for a child in your family, I've got services that can help you. You can head over to jillcastle.com and check out my private practice services. That's it. In the meantime, and every day, I hope you do this. Give that child in your life a loving squeeze today. Bye for now.
Thanks for listening to the Nourished Child Podcast, where the #1 goal is to help you grow a nourished child, inside and out.